we'll take questions from the audience. I'm going to pull some Oprah action and circulate and take questions. Again, Caitlin is here for the conference. If you are interested in getting involved, please visit with her. They're happy to help guide you through the process of registering. I actually am a member of the IDUA expert curation panel. It is an exacting process. They are developing rigorous data, and they're going to be also publishing their specifications, which will help future researchers know how to report data in the optimal fashion. And the other issue too, I think that's important is to go from a variant that is novel to getting it published with clinical data. That will take years, and that's years of delay that it is not provided to the clinical community who may be needing to make clinical choices about how to approach treatment. So I think there's real value in this. If there are no other, I don't see any hands. If they're not, oh, excellent. Thank you, Anna Marie.
Thanks, Matthew. A question to you all, I guess. Great presentations, a lot of detailed information. Just picking up on the theme, Amy, where you talked about collaboration, collaboration, collaboration. I was just wondering what kind of international networks that you're all working. These are rare diseases, global populations. Just if you could speak to the global collaboration.
Yeah, I can start and then of course pass it on to others. Great question, Anna Marie. I think in the realm of newborn screening, it is becoming more and more important to have, I think, global collaboration, because as you mentioned, we're talking now not just necessarily about rare diseases, but ultra rare diseases. And so one of the things that I probably failed to mention with the RUSP process in particular is that you can use international data as part of your evidence. And for metachromatic leukodystrophy, which is going through the process right now, we leaned heavily on international experience and data. And so I can't speak highly enough of how that process has gone. And I think in terms of not just newborn screening, but in that data piece as well, the more variants you can get from the more sources, really regardless of whether they were on US soil or not, is really helpful. So I highly encourage global collaboration for not just newborn screening, but for data sharing and truly understanding, potential impacts of phenotype and genotype.
So just a point of clarification, Caitlin, even though these programs are financed by the NIH, they are available for international participation and also for international depositing of data, correct?
Yeah, anyone who's had genetic testing can join Genome Connect, and we will share that information with ClinVar. We have one limitation, which is participants who are currently residing in the European Economic Union because of GDPR regulations. But everyone else, we have a large cohort of people who have joined from Australia or from Brazil. Those are just conferences that we have recently been to, so that's why they're coming to my head. So I don't mean to, eliminate anyone else.
Excellent. We have a question from Joe Munzer.
So why this restriction on data sharing in Europe?
I will have to let you ask our IRB, which is the Geisinger IRB that regulates the Genome Connect. And because of the GDPR regulations, we just can't fully confirm that any information that's shared from the GDPR will be removed from our servers. It is something that we're always evaluating with our IRB, and we do allow folks to register and they get a notification that they're not eligible at this time. And as soon as our IRB changes that regulation, we have an email ready to go out to those participants to join. We have worked, as Jenny has said, with the ACD. And so we've done different ways where we have trained other people to curate their reports and share that information and share the de-identified information back with us. And then that's a way that we can submit it to ClinVar.
Other questions?
Not really a question, but our son, he has a variant of unknown significance. So I noticed the room kind of thinned out. I don't know how many families are affected by that situation, but unfortunately ours was. So if any family stayed to learn about this, I'm just an example. My son's not next to me right now, but he was found on newborn screening. And unfortunately, because his variant is unknown, obviously we know it causes disease now. He's just on Elaprase and not a candidate for any trials. And it's just a really hard place to be in. A different, I don't know if new type of heartbreak, but just to kind of share a little bit about us and thank you for everything. Hunter syndrome.
So that shares that underlies the importance of being involved in these sorts of situations. There are going to be variants of unknown significance for recessive diseases, for Hunter. The more data we have shared from patients, the better.
Yeah, and if I can just say thank you so much for sharing that, because as we continue to do more newborn screening, I do think we are going to see a lot more variants of uncertain significance, and we'll put a lot more families in that boat. And so it's that balance again of we know we're doing well by screening, but we also have to acknowledge the traumatic experience that we're putting families in, especially around uncertainty. And this type of work of data sharing is so valuable so that we reduce those numbers and we don't have patients out there who know their child has disease but aren't eligible for trials as well. So I think your story highlights so many things, and just thank you for bringing it up.
So, so Amy, I think it's important to let people know that just because you have a variant of unknown significance, in this case in the ironic 2 sulfatase gene, doesn't mean you don't have that disorder. When we have enzyme deficiency and elevated urine gags or evidence of storage. So you may want to just comment on that because some people get so hung up, excuse me, on having this very unknown significance. Maybe they say, does my child have the disorder or not? And it's important that we sometimes over interpret the variant of the interpretation of the DNA when we have other things. As you both all appreciate, for other disorders where all you have is DNA, then it's a very different issue.
Yeah, I think, I'm sure Dr. Gelb has a lot to say on that, but because I know he does. But you're right that I do think society puts an interesting emphasis on DNA information. And I don't know if that's because of CSI and Grey's Anatomy or what, exactly, but it does speak to how important it is for us to take the holistic context of the workup, including the clinical evaluation, the clinical presentation, and the biochemical. And I do think, especially as we roll out newborn screening, we're going to need to do a lot in explaining that to primary care providers as well. So I appreciate that reminder.
Yeah, I mean, what Joe Munster says is absolutely true. And in fact, almost always the biochemistry is more prognostic and informative than the DNA. And I don't want to dwell on this, but pathogenic, so VU doesn't mean no disease, and pathogenic doesn't always mean disease. It's even worse than you think. For example, for recessive diseases, let's say you have a late onset disease and you have 2 pathogenic mutations. One of them is often a severe one and the other one is late, and that's why you have a late. But now what happens when you have late, and they're both pathogenic, and often you have no disease. So pathogenic, so VU is a dirty word, and so is pathogenic, by the way.
I think we're all in agreement that, it's one thing to classify an individual variant, and it's a whole nother thing to look at the full genotype. Exactly. So yeah, I think again, I know sometimes this has gotten you in trouble, Mike, but you're right that the genotype itself, the combination of variants, whether they're in cis or trans, is fundamental to our understanding of what might happen.
Michael, thank you, Michael. I'm going to have to shut this down because we are at time. I do want to refer to both points that Joe and Michael have brought up. There are classifications that are put into ClinVar, and then there are classifications that go through the expert curation panel system. Those that go through the expert curation panel system, they incorporate concerns that you have raised, Michael. And that's one of the values of standing up things like this VSET panel for iduronidae and expanding it to others and to incorporate data, et cetera. It will help future individuals that may be diagnosed with these alleles. Thank you for this group to have stayed so long as I conclude the formal program of our first day.